So, dear colleagues, thank you, Dr. Iakovou, and also thanks to the organizing committee for the kind invitation to participate at your great conference. I would like to present a case, severe degenerative MR. This is our heart team at Hygeia Hospital. Our patient, 87-year-old male, BMI of 21.5, dyspnea near 3 to 4, known severe mitral regurgitation for several years. In the echo, LVEF of 73%, degenerative MR with ERO of 1.2 square centimeters, ECG chronic atrial fibrillation, and then normal coronary status from 2016. So we see on the day of admission the X-ray and the labs of our patient with a BNP of 316 at this point. Comorbidities, hypertension, atrial fibrillation, prostate hypertrophy, and on the medication of the patient, we see also a high dose of diuretics. Our approach to those patients, we always consider factors such as which is the mechanism of the regurgitation, the severity, the jet number and location, the leaflet morphology, the leaflet length, and the mitral valve area. So our patient has a dilated left ventricle with an adequate ejection fraction. We see the dynamic heart model and the global longitudinal strain. Severe degenerative mitral regurgitation, as we said, and the quantification of the regurgitation with the ERO of 1.65 square centimeters. The tricuspid valve shows at that point a moderate regurgitation. We see here the commissural view with a severe MR. And the live 3D multiscallop prolapse and flail in segments, especially at P3 and P2, with, as we said, the severe mitral regurgitation. We see the biplane analysis of the mitral leaflets in area A2, P2, and falling to the A3, P3 area. And we see here the 3D, in the 3D nicely, as we said, the highly degenerative valve. And here also in the glass view. We have a big mitral valve area of 6.8 square centimeters. And as we use, and more often it's really helpful, the MPR analysis here in the medial A3, P3, and the central A2, P2. Additionally, the patient had a PFO. So the summary for echo findings, the mechanism, a degenerative multiscallop prolapse with flail, mainly the P3, P2 region, severe regurgitation, multiple jets, medial and central, indentation in P2, P3 segment, long redundant leaflets, and mitral valve area of 6.8 square centimeters by the 3D planimetry. The right heart catheterization, elevated PA, not as much as expected, but as we said, the BNP was only 300 at that point. So we discussed in our heart team the case. We considered the surgical therapy, although in this patient we see a very high Euroscore 2. In this consideration, we thought if it would make sense to repair the tricuspid valve as well. Our heart team decision was to proceed with the TEER, since we were quite confident that we could help interventionally also our patient. So we have more than one devices likely to be needed. Our plan and strategy was starting from medial commissure. There was the need to secure the flail posterior segments. The valve area was good and would probably accommodate easily multiple devices. Of course, we would monitor the gradient, and we knew from the beginning that the elimination of the MR was not likely possible. So our strategy, starting from the medial commissure, and the plan was to implant 3 devices. At the beginning of the procedure, no thrombus in the LAA. Our transeptal puncture was not problematic. We see the very high V waves of our patient. Here is the initial positioning of our first device, the Pascal ACE, which was not commissural enough, so we positioned again in the medial commissure, and we see the clocking of the device counterclockwise. We followed the independent anterior clasping, independent posterior clasping, and then we optimized here, we see on the right side, the optimization of the anterior leaflet. We were confident about the clasping of the device, so we released here we see fluoroscopically the release of our first ACE device, and this is the outcome of after the release, which was quite acceptable at the area of the first device. Here's the glass view. Positioning of the second Pascal ACE device, also a counterclockwise rotation, and we see here the clasping of the device after we moved the second device closer to the first one. So I will move on. Good gradient after the release of the second device, positioning of the third device closer to the other two since we have color between the devices, and we assessed the situation and then were satisfied about the outcome and released our third device. We see here the fluoroscopic images. Good outcome regarding the hemodynamics, and this is the MR reduction after the procedure with a mild residual MR and a mean gradient of 2. And this is the 3D mitral valve orifice area of 2.1 square centimeters. These are the final glass views of the patient and the hospital course. The patient was discharged on day 3 post-procedure, and this was the final echo at discharge. Thank you very much.
This is a very tough case, an excellent outcome and the presentation. Well done. So it's, this illustrates the importance of the heart team. You know, we discussed, I suppose, this is a yellow to red zone case. So it's maybe we shouldn't have tried that. In the early learning phase. So Nico,
and there was a Barlow type valve. So I saw there's some products of the anterior parts as well, not only the posterior. So congratulations, excellent result.
Thank you very much.
So any other comments? Dr. Zarogiannis, would you try this patient to clip it? There's a microphone over there, maybe.
It's better now? Yeah.
Yeah.
Sure. Although the good thing with this patient is that the valve area was big enough to give us space to try three separate devices in order to achieve that result. But it was a great result. Yeah, I would certainly try it too.
Do you think there is any advantage of the Pascal over mitral clip in such case? In a Barlow type valve.
It is our experience is that in such cases we have to use devices with a firm clasping. This could be. Sorry. In such cases, our experience says that we have to use devices with firm clasping as a Pascal ACE. But as we mentioned before, also I think a mitral clip would also have a good outcome in such cases.
Thank you very much.